बैंक से आए स्कैन करके है तेरे पास किया मतलब बंद कर दिया दर्शन अच्छा इससे तो इंटरनेट लिया हुआ है उसको कर हाँ इससे तो इंटरनेट लिया इसको गया इसको स्कैन कर अदुआला मैं तो करके ठीक है ना ऑडियो की जगह पे म्यूजिक दे देते हैं ऑडियो म्यूट कर देते हैं प्ले किया और किया देखते हैं इसका चेक कर लाइव पे क्या कह रहे हैं।
Hello. Check 1 2 3 4. Check 1 2 3 4. Check.
I take great pride in seeing our academic cycle begin with such a cutting-edge program. Today, we focus on silk surgery and evolving frontier in corneal refractive surgery. This workshop is not only about learning techniques, but also it's about sharing our knowledge and growing together as professionals in the field of cornea. I want really to express my sincere gratitude to our president of the group, Dr. AlBarry, for his constant support and vision that make this initiative possible. I would like also to acknowledge and thank Amico Group for their valuable sponsorship. Being an industrial partnership with this group has really an instrumental influence into this academic event. I invite you really today to engage, to ask questions, to network with everyone in the room here and enjoy this event. Let's build really a strong community, and let's being together and work together to make a brighter future for our refractive surgery in our region. I would like to thank also our distinguished speakers, the world-renowned expert, Dr. Rohit Shetty, who was able to make this event, and he's staying with us only for 20 hours with all his busy, schedule. He was able to visit us and share his experience in silk. Also, I would like to thank Dr. Waseem Aalam, who's well known to all of us for his also generous visits to Riyadh, and of course, audience for being with us today. So I would like now to handle the mic to the president of the group, Dr. AlBarry, to introduce Prof. Rohit Shetty.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuhu. Thank you all for your kind attendance, and thank you, Dr. Samar and Dr. Abdullah Aljenaidel for organizing this meeting. And thank you so much, Dr. Rohit Shetty. I know you have a very busy schedule, and you're flying all over the place, and you have so much family commitments. Yet you were very kind to accept our invitation and come for 24 hours. Really, Dr. Rohit Shetty needs no introduction. He's a very known expert in refractive surgery. He's the director of Narayana Nethra Eye Institute at Bangalore. He has more than 200 peer-reviewed articles and publications. He's a world expert in refractive surgery and has achieved so many achievements and awards internationally in America, in Europe. So we are really privileged to have him with us. And thanks again to Dr. Waseem for sharing his early experience with the Silk Elita. I'm sure this meeting is going to be a very fruitful one. Dr. Rohit is going to touch on the scientific core of this technology and how it has introduced something new. Thank you, Dr. Rohit.
I need to start from first the slide. Good afternoon, and I'm really touched and honored to be here with good friends, and we've been meeting for many conferences. So when I was asked to come down here to speak about something which I've been involved in for the last 6 years, we started the first human trials of silk just at the beginning of COVID. So it was a very new way of looking at a formulation of a trial. There were two things in front of us. One is to stop the trial and wait for the COVID to get over. At that point of time, we didn't know when it's going to get over. The second option was to continue with the trial, but nobody could travel, and there were 9 or 10 cameras in the room, and all the cameras were linked to people in US, Europe, and other places to see how this machine was functioning. There were cameras put here, put there. So one important thing which I learned during this trial is so much of scrutiny on every small aspects of yours. So what happened was, looking back, I refined my techniques better because a camera was put here. Somebody would say, "Doctor, there was a little tilt of your suction." We never look at it. So that's why when we go back, a lot of us still don't want to acknowledge COVID because it's not a great time. We lost a lot of good friends and relatives, but it also had a good lesson. So my teaching today, what I've done in the last 5-6 years of more than 3,000 eyes, is what I've learned through those initial phase with Alcon. And I have 2 talks. One is just about basic, and both my dear friends would know that I'm also a biologist. I work on molecular biology. That's my PhD. So I try to bring in as much biology to the surgeries as possible, because in today's context, it's more that biology speaks more than the lasers. Whatever you do on this machine, when it hits the eye, it's the biology there. And biology cannot be controlled. So that is something I want to acknowledge before I start. These are my financial interests. When I see patients coming to us today, it's all about not a clear cornea. It's about good quality of vision. And most important now, I'm sure all of the most accomplished cataract surgeons in this group, everybody wants a depth of focus. That's how EDOF has come. Depth of focus is becoming more important because now you're looking at an intermediate vision, which is the significant part because that's your computer and then your distance and the reading. So I will come to this later, why some machines we lose the depth. We all know that when we change the corneal shape, this collaboration goes and we lose the depth. This is like Dr. Professor mentioned, this is a two-way meeting. So at any point you can ask, you can lift your hand, and this is not a talk. I'm just sharing my experience, so you can disagree, agree, or we can discuss on it. So whenever you want, you can just stop it for you also, so that we can have a discussion on this. So what is unique here is it's low energies. This is what is most unique. The rest of it, every machine can say. I use all of them, except Zima. I use Atos, Bisumax 500, 800, and I was also the first human trial of Atos were done by us. And maybe in 3 years you'll have one more thing which I'm doing the study now is Alcon's UV laser. That means the laser is based on a UV platform. So you can see that it's very small, and the other one is the shape of the lenticule, which is important. So low energy, fast, short pulse. And what is unique here is it's a very, very small spots and no spot-to-spot separation. Important thing is if you take a paper and make with a pencil and keep making holes, which is very close, and tear it, it tears off immediately. But make a hole, give space, it's difficult to tear. So that's what the whole thing is all about. So what we did was we used different lasers, and we used the confocal microscopy, and this is the ocular scatter index. When you have higher energies, this is on the corneal stroma and keratocyte. You see this honeycomb shape? These are fluids. When you more the energies, you get those scatters. That's why many times you don't get the same quality of vision as you would see with an excimer laser, because the laser energies would create this change. And you need a smoother dissection. For example, when you use this, there's no spot-to-spot separation. It's a very smooth dissection. And every time there is a lasers, when there are thousands and thousands of keratocytes here. So when you have no spot-to-spot separation, this area will create a lot of fibroblast changes. And that's why biologically it's very important that you don't end up in having too far away spots. That's also not good. I teach this to my residents. I call the mindfulness in any surgery. I'll come to this in my second half, why everything is important. So many times as surgeons, when somebody comes and gives this machine, we are very happy with it because it's a new machine. There's a beautiful optics. J&J is a company which we trust. But 90% of the time, the lasers are not the problem. It's about all of these. The speculum, the mebum, which all I will discuss all of them over in my second talk, how much pressure you do. These things make it a perfect surgery. So I'll run this video. This was presented at the ESCRS near live surgery session, marking. And every, this is important because it has a cone. You have to PI scan just to see that the optics is all perfect. This is how it's very important that, there's no scleral show. The vacuum is put. And people who use intralase, it's more or less exactly the same thing. And this is very important. I'm sure there is it's like if you don't go in, it's like your basketball not going inside. And here it goes in like a basketball going very smoothly. This is important. Once it goes, the laser settings, each lasers have different patterns. Some people have gone up to around 38, 39 nanojoules, which is the lowest. And you can adjust your centration. This is what we started with. And this is a raster pattern of laser. The profile of lenticule, we did our mathematical modeling. You can see that is a biconvex lenticule that is on the Zeiss. And you can see that even today, one of the most beautiful things about the surgery is it dissects so smoothly. It's like silk. And I have apart from doing the study, I don't have. This was the early studies. I still needed some dissection. But the present one hardly needs anything. This is the anterior and posterior dissection. And coming from a platform of Smile and Atos, I feel there's nothing to beat the way this is dissected. And you can see that when you're learning, sometimes, you put too much of pressure. You are trying, because this is important. This is the vertical height. And, something around 2022, when some people go up to here, that means you're compressing the cornea a lot. That's something which probably will be discussed during your wet lab practice. So the low energy helps us to dissect. It's a one sweep dissection. And we don't even need to dissect. Then we realized that it's so beautiful in terms of how you can, how the lenticule is created. We thought you don't even need to dissect. And this is called Puil. You can see. Now we don't dissect at all. This is it. That's it. This is what our surgery now is. And reason is important is no other technology, because I have other except for Zima, you can do this so smoothly because it's already dissected. The challenge is the quality of vision. This is in Asian eyes. We reach close to 96% on 20 by 20. We tried on low myopes. Same results as you would see with the excimer lasers. Still, the cyclotorsion has to be manual. They don't have a cyclotorsion thing. I'm sure they're working on trying to find an eye trace to do it. So you can see that you have a marker there and you align it to the cyclotorsion marker. We worked on high astigmatism. We compared with Contura. That's very interesting. We have Contura. Now I'm working on Wavelight Plus. Exactly the same. Hardly any difference. This is in review now, the article. The question people ask is, can the lenticular shape impact the clinical outcome? This is what it is. It's a biconvex shape. There's a lot of people debate on it. even if it's a biconvex, once you take out the cornea, remodels to the same shape as it was. It's got its memory. So what we did was we did a 3D reconstruction. You can see that this is an anterior and posterior. It's how nicely it fits. This is a smile one. I think Zemer also has something similar. It was something close to this, but not as much as this is. So question which was asked is, can biconvex shape have an impact in your clinical practice? So we did some mathematical modeling, and what's interesting here is the change in your corneal curvature gradient from the periphery to the center was much lesser than what you would see in a smile or what you would even see in an excimer laser. This is the first thing, that there is a difference in how the cornea reshapes. The second thing is we have our own mathematical modeling team. There are some 5 PhDs with us. So we did some modeling work, and then we started looking at what does a biconvex shape do. The arc length of anterior and posterior are similar in a biconvex. So when you create this model, and this is on a smile, we found what does it do is the relaxation of the cornea is much better on a biconvex, and the stress on this many times comes on the Baumann's. So we started looking closely at the Baumann's layer because of this. Baumann's layer wrinkles is very difficult to pick up. Most of our OCTs are 5 to 6 microns. The Pentacam OCT is new. The resolution is still around 1.8 microns. And you see such beautiful Baumann's wrinkles here. And Pentacam OCT, you can actually even, you can even separate the layers of epithelium, the basal cells, the superficial. So it's a beautiful OCT. I'm sure in ESCRS, we've been working on this OCT. We helped them to design this. And look at this. This is the Baumann's wrinkle. We had published in the past. The Baumann's wrinkle is one of the major reasons of poor quality of vision. And what we feel is when you have a less stress on the system, like what I showed here, the wrinkles should be less. So what we did was we looked at the Baumann's. We do the ironing. We call at the end of the procedure. What I do is 10 times we just do ironing. It just removes all the wrinkles because it relaxes the Baumann's layer. This is something which we published, and ironing and no ironing, which has helped us to. This is one very important point. Then we started looking at the corneal nerve. There's always a symbiosis between the corneal nerve, epithelium, and healing. And this is one of my major areas of work, is when you have a healthy corneal nerves, the epithelium heals in a nice and beautiful way. A poor corneal nerves makes the epithelium, because every epithelial cell has one small nerve fiber in it, every cell. When you go to neurology, the nerve has a Schwann cell, and that's the outer covering of a nerve. Ophthalmologic cornea nerves don't have Schwann cells. Epithelium becomes the Schwann cells. They cover it well. So every time you have a nerve which is damaged, it secretes nerve growth factors and neurotropic factors, which changes the epithelium. So we started looking at very deeply using very high resolution OCT when I did show to some of my friends who did not believe that the biconvex has a real role in the post-op healing. But sir, can you see this is the same OCT. The right eye was the silk, this one was the smile. Can you see this more flatter? And can you see this more curved? That means it maintains the shape of asphericity. Now the same patient, if you really look at what happens to the epithelium, there is an epithelial change. This is the epithelium post-op. This is the epithelium post-op. So look at how beautifully it's, and what has happened is, because there is less to remodel, the epithelium hyperplasia is less. And what happens is, because of this, look at this, there is 75 here, and 54 here. There is so much of coma aberrations driven by the epithelium itself. We used the Precisio abrometer to look at different lenticule surgeries. Precisio gives epithelium in dioptric. That means it gives how much of ray tracing, how much of myopic shift the epithelium is creating. You can see different types of epithelial maps. But when you see the smile, silk, it's bang on. There's no myopic mirror in it. So it just shows the power of healing. The question is 20 by 20 enough? And we need today very high contrast vision, which is what we all want. And because we are not changing, if you go back to this image again, and we all know that anything which is flatter pushes your spherical aberration to your negative. Anything which is curved, that means it is preserving your essay. So when you preserve your essay, what happens is your depth of focus remains unaltered. And today, all our patients, I'm sure anywhere in this world, we need depth of focus. So we published this work that the depth of focus is good because you're inducing the minimal amount of essay. The amount of essay induction is as close to as you would see with the best of procedures on examer, wavefront guided or wavefront driven procedures. This we published just a month back on visual performance at different levels. We did the depth of focus. The depth of focus, there's not many papers on lenticule surgery on depth of focus because depth of focus is very difficult to measure and publish. And we already had a paper on myopic LASIK that was Contura, Silk and Trans-PRK. So we had done it with so what we did was we used the same process and we used the depth of focus, and most important thing was Silk had one of the best depth of focus compared to all the other platforms which is shown. So how does it help? One, it helps your young patients who come to you because they don't get tired at the end of the day, they don't get headaches, they don't get strained because they're not focusing, refocusing. And second, very important thing which I want to say is, I advise this to my pre-presbyops or presbyopic patients because if the green is somebody like me who is presbyopic and not had any and no refractive error, and silk is the blue. So after you do even a -3, 4, 5, you have changed him to exactly similar to what a pre-presbyop or a presbyop of that age group. That means that you're not making him worse. Normally you do a myopic surgery, the person loses his depth of focus. So I did around 40 patients so far who are around between 42 patients who are between 38 and 52 years. I'm not saying that I've given them a presbyopic correction, but I'm given them a small EDOF-like thing on the cornea. So if there is a role for a presbyopic lenticule surgery, I think the best machine today who can actually take it forward is Silk. So what I'm saying is now, last 2 years, I advise this to my patient that compared to the other, this has a better depth of focus. So a lot of patients enjoy it. And they say that yes, and if you look at my other machines, it makes a huge impact. So I'm just going to touch upon in this part of my presentation, the devil is the biology. Because every outcome of it is driven by how your basal inflammation is. And this was written by one of my PhD students about how when you do any surgery on your eye, on your cornea, you have those waves of healing. The waves of healing is what makes you to heal without scarring. And the waves, when it's exaggerated, then why does it exaggerated happens is because these molecules are becoming a trigger. It's been always an enigma to study these molecules because we know it. We have studied in the textbook. We know it's there in the immunology books. But how do I check in my clinic? So that's what I presented in last 2 years back when I'd come to Jeddah, that the point of care now, you can take a Shermer strip, put it in kind of a machine, and you get an AI-driven report with every molecules, and it will tell you on which side of it. Now, the question is, when will this be commercially available? Now I can say next year. The next year, hopefully I'm here. We can talk about one of you or these hospitals can use it. It's as simple as doing your normal Shermer strip, which you throw it, or you can take aqueous, vitreous, anything you want. And this is done by a small, any student. And this is, you take the buffer out, and then you get all these molecules. There are this is you're looking at glaucoma, you're looking at uvea. For example, you have a VEGF here, you have a ICAM1, IL-17, you can take CSF, virtually anything. So this has a completely changed the way we look at immunology. It will change the way we look at retina, way we look at every aspect of biology. Because when we look at how the laser changes the keratocytes, it's inflammation. More inflammation eyes will have more keratocytes changes. For example, if the person has a dry eye, you treat the patient with your silk smile, his keratocytes will behave like this. This is myofibroblasts. So what we blame normally is we blame the machine. Oh, there's something wrong. One of my patients is not seeing, 10 of them are not seeing. But go back and start looking at your biology. Consistently, it's your biology, because machines don't change so much. So what is important is, which I'm going to discuss in the second talk of mine, is if you harness the biology, the machine will become even more robust. Because skill is you can pick up very quickly. I mean, you can go back. It's so easy to operate because there's no dissection compared to the other thing. But what happens is understanding biology is probably very important, because a good laser, like you don't hardly see any keratocytes change. This is just the day one. And look at when you have high energies, look at the amount of fluid here. And when you have fluid, the patient comes to you and says, I don't see as well as I should be seeing. I see something cloudy. When you say cloudy, it means that there is some fluid. And you see on slit lamp, you don't see fluid because confocal is 800 times magnification. I can see all these pockets of fluid. And this will go after a week. So now I can see better. You don't see this in LASIK because it burns, it ablates. Because here, the laser energy pattern is completely different. And this is all biology which helps to look at tissue. So what is important here is understanding this inflammation is very important, because if you are treating on a dry eye and you do a silk or smile anything without taking care of his dry eye status, you will have more of this edema. So you have to be mentally prepared that dry eye patients behave differently. Contact lens patients behave differently. If I'm doing a contact lens wearer who's never been unhappy with contact lenses, you're dealing with extremely high level of inflammation like this. And this is a patient of mine who look at the epithelium is so thick, and look at all the markers are very high. And I did this silk on him. He was not happy. And if you look at this edema, look at the edema out here. There is so much of edema in there because it was same surgeon, same machine, same laser. It's because there is a huge amount of inflammation in every patient you operate. So what I should have done for him, which I'll discuss later, is I should have probably treated him before, or I could have probably put him on cyclosporin for 2 weeks. I could have stabilized this inflammation. What happens is when you treat him before, or you do an LipiFlow highlight, is you reduce this inflammation. One of the worst thing to have to do it is your TNF alpha and MMP9. If you do it, you swell, the cornea becomes edematous. So remember one thing, the details, the devil is in biology. The biology has to be harnessed before we do any of these procedures. This is going to be published very shortly. The corneal nerves being cut is very minimal. You can see the blue is silk and the Klex is smile. It also cuts the nerve, but the recovery is very fast. This corneal nerve length, diameters, density, distance. I can see that the nerves heal faster. Why does it heal faster? Maybe because you are actually giving less energies, or maybe because of the pattern. When the nerves heals pattern, this is the work done in my lab. This is corneal epithelial cells. If you have a healthy nerves, look at how the cells, like how we all meet as friends here, look how they start talking to each other. And when you don't have corneal nerves, these cells don't function. See the beauty of it. I can play this as, and these things are lysozymes tracker. They are necessary to make your cornea, necessary to take care of the dead cells. This function of meeting just disappears when your corneal nerves are not there. This is a very important function of, we created this model on this. The corneal nerves have pain. More than pain, my most important thing now is nociceptive. All of us are sitting here comfortably with this AC without having a problem because our ion channels are functioning well. The next wave of lubricants is going to be trying to see how these ion channels ion channels are necessary for keeping the nociception intact. That means I am not bothered about the light because my nociceptive receptors are healthy. One important thing is when you don't cut the nerves, patients don't come back to you with nerve pain. They will always come with vague symptoms. I can't see bright light, computer screen hurts me after LASIK. And I don't feel happy at the end of the day. And all this is driven by the nociceptive factors. So we looked at nociceptive factors and we feel that this has a huge important role. So when you look at harnessing the biology, it's beyond optics. That's the second part of thing, how I'm going to speak about how I mindfully look at them. Tear film, corneal nerves is not just about sensation or dry eye. Those are secondary. It's about today nociception. It's about how the nociception is directly linked to the quality of life. Patient may have a 20/40 vision, but he's happy because his nociceptive factors are good. There are times when they have a 20/20 plus vision, but the nociception is bad. They're terribly unhappy. And that's what is important. And the neuroadaptation and biomechanics of healing is probably very important. That's why the biology is very, very important in irrespective of how smooth the machines are. So at this point of time, in my first part of my talk, which is just about experience of silk, we have finished, we do around 3,000 odd plus cases now, last 5 to 6 years of using. I have done only one recorrection. Its nomogram is bang on, and we don't have a suction loss because when you put this suction here, there is a certain amount of force of the lids, the suction force, the squeeze force. It comes in some newtons. When your suction should be at least 2 times stronger than that suction force of the patient. But what happens with the smile is, it is lesser than the suction force of the patient. So what happens is, when you there is a lot of suction losses, which we have not seen any suction losses. It has a very good laser firing system. I personally believe, based on my patient experience and my patient and the research experience, that the biconvex has a tremendous impact in the quality of vision, even though there are a lot of people who debate on it, and nobody knows who's who. But so far, the work shows that it has a more controlled spherical aberration and more controlled depth of focus. Corneal nerves healed very fast, and my take on today's corneal nerve is its ability to take care of nociceptive factors. It's not just about dryness. And I presume that because the healing is good, the collagen matrix layover and healing must be good. This is just an hypothetical one. I feel that that should bring in more biomechanical stability. So this is my take on my experience of the last 5.5 to 6 years, and what I've understood and what I've researched on this. Thank you.
Thank you so much, Dr. Rohit Shetty. Very nice and interesting talk. Now we can open the floor maybe for some questions. We have a very enthusiastic audience here, and we're very excited about this technology. Okay, I can ask you maybe the first question. You've mentioned that you've had only one redo out of 3,000 cases. So can we say that the percentage of reaching target vision 20/20 or above is like 99.9%?
Absolutely. See, when we started off with trials, we had a lot of nomogram issues. Now, most of you, whatever you're using nomogram is based on the work we did, and it's quite bang on.
And the redo, how did you go about the redo? Did you go
we
to
did that. No, I did a P. It was just a 0.75. I did a PRK.
PRK. So for now, it's better to go for eczema if you want to go for a redo.
Even the people I know of, there are 50 odd centers which are doing now. I know at least 2 or 3 who have been doing it for last 3 years. I have not heard them doing not many redo procedures. So it's biomechanically more stable. So that's why, you don't get regression. And the second reason I feel there is less of regression is because the epithelial remodeling is very minimal. One of the issues why we get remodeling is because when you have too much of epithelial remodeling, you get 0.5, 0.75 diopters of things. So I feel that may be one of the reasons.
Okay, you also mentioned in regarding to the corneal sphericity and spherical abrasion induction, you've mentioned in one of your papers that the new silk has superseded even eczema in the perillicity, in maintaining the perillicity of the cornea.
Yes, we compared with Contura then. I'm not compared with the Wavelite Plus. When compared to Contura, Trans-PRK, Smile, this maintains better sphericity, maintains more sphericity in spite of taking the same amount of power. That's why when you see the post-op pictures, you don't see a central flattening here. You see some kind of sphericity there.
Even with the epithelial mapping?
Yes.
You've mentioned in the talk that basically it's overtaken in other platforms, in the pulse duration, the energy, the frequency, yet the lenticular creation is still significantly longer than the other competitors.
Yes.
Why is that?
It's lesser, it's longer compared to the new Smile 800, which is around 8.5 seconds. But it's I think it's more or less the same compared to the ETOS and I think the Zemer, which I'm not. Even Zemer is around 18 to 20 seconds, I guess. I may be wrong. The reason is it uses a raster pattern and it has more spots. Okay. So when you have more spots, it takes a little longer time.
Dr. Majid. So why is it raster? Because the competitors are doing it in a second.
I think it's just how they feel that, because you need more laser spots to fall on, because see, all others have a, you have a spacing, your track distance, your spot distance. Here you have multiple spots. So one of the challenges they had initially was having too many spots. Is it increasing the cumulative energy? A lot of people did ask me this question that you're going to burn cornea with so much of spots. But when we showed them the confocal images of maybe 300 odd patients, it did not show any changes. That means even though the spots were there, but the plume effect and the ability to create heat there was very minimal.
Thank you so much, Dr. Shetty, for being here, and thanks for the colleague for organizing such a great event. So I will start with one question that was raised by Dr. Maan. You mentioned in your talk clearly and nicely the comparison of spherical aberration in silk with others, the platform like eximers. Did you compare like Q value adjustment with excimer with silk? Like if you do excimer laser, but you adjust the Q value to make the spherical aberration higher to maintain some depth of focus?
We debated whether we should look at the Q value. The reason we did not compare is we looked at all these patients at the 4th or 6th month. The reason is what we realized, at least in a population I come from, even if you adjust it, the epithelium creates a mess which changes all the Q value. So we thought, let's do it after 6 months, irrespective of Q value change, and see what happens. And all of them we controlled their dry eye and other things, so the epithelial rebonding was very minimal. But in spite of this, it was doing better than the other competitors, especially in spherical aberration. Both papers are published.
Yeah, but my point is, as you know, when you go for like contoura or transepithelium, you could target the Q value, changing the target Q by inducing more spherical aberration.
That we did not. But I had given the suggestion to the R&D team that they could use this as a Q value change for presbyopic treatment, because for presbyopia, when you do a -3 with the LASIK, if you're a 43, 44, you start complaining. But when you do this, he doesn't complain, because he still has that small depth, like a 43-year-old normal person.
Okay. Second question, you mentioned clearly the neuroinflammatory cascade, as it's now added to the dry eye workshop classification, the new classification. You should target the neuroinflammatory markers, and you are one of the world experts to hit this one. So do you think there are like a new agent coming in the pharmaceutical companies to target this inflammatory neurocascade?
See, for example, if I just go back to this image out here. Say, for example, if you really look at, this is a classic cascades of it. We picked, the same cascade works in retina also. You take the vitreous, the same cascade. For example, the people who don't respond to VEGF have a problem with the ICAMP1. And people have IL-17, recurrent erosions like we see in many parts is driven by this. But unfortunately, we have very few targets. For example, we have MMP9, we have a target, which is cyclosporin. TNF, we don't have a target. We have a lifitegrast, which works on this. So the next generation medicines will start working on many of these targets. Next generation medicines for retina also will start working on it. The same map works for retina also with a different AI model. So Alcon, what is Alcon doing? I was telling them in the discussion is they're coming out with a drug which...
the honey one?
No, they're looking at improving the ion channels. That they are going to increase it so that you get a cooling effect, something similar to that. They are putting drops, the other company is using a patch. So a lot of work is happening on it. So next generation dry eye is going to move away from lubricants, is going to move towards a targeted therapies of one of these.
Okay, so I asked many questions. One more question is, when you started the Film to Smile, then you shifted to Silk. As you know, when you start the first 10, 20 cases, you need to adjust energy with the humidity of the room. You might work in one center, other center. You have different settings. Does this apply to Silk when you started few cases?
Very minimal. So only thing is, don't start with very low, like how an expert starts, because sometimes it may not work. You gradually start. When we started for the trial, with 60 nanojoules. So when it comes to your clinic, now they're giving it 40 nanojoules. So that means 60 was considered very high, and we gradually reduced 5 nanojoules to a stage where some people are looking at 35, 38. But we have not found any big difference between 38 to 45, but more than 45, your quality of vision drops, because more energy creates corneal edema, which you don't see, confocal edema. So between around 40 to 42 is the sweet spot.
Okay. Last question is about your thought about the effect of tacrolimus and tumor necrosis factor alpha as an anti-inflammatory marker being off-label.
The tacrolimus is 8 times more potent than cyclosporin. So, but what it does is, if I use this map again, which helps me to look at it, it works tremendously on this, which is your scar forming agent. It is decently working on MMP9, and it has some role on IL-6. So Reason it works very well for scarring because it works on tumor necrosis factor T alpha, which cyclosporin doesn't work very well, and steroid causes more changes, and you don't have too many options for it. That's why when you have a scar, the two scar forming are this and this.
At what concentration was that?
Yeah, concentration.
No, at what concentration of tacrolimus?
Um,
Because we tried many
we have, I mean, what we do is we use the skin ointment on the
Okay,
lids.
0.003.
Yeah, so that is what is working.
Thank you so much.
Okay, Dr. Ali.
But one important thing is, when your patient comes to you and he has too much of symptoms and neuropathic pain, one of the factors which really implicated is IL-17. And for that IL-17, the neuropathic pain is driven by it because this has a role in the hemidesmosomes. That means two epithelium becomes looser. So that's why most of the time you don't see any changes. It's called pain without stain. And this works very well with lifitegrast and IPL therapy.
What was that? Pain
The
without stain?
IPL, the IPL.
The IPL, okay.
If you have a patient who says after LASIK or some surgery that I'm not getting relief by any medications, we publish it in Cornea Journal. IL-17 works very well with it. Yeah, 2 sittings of IPL therapy, it knocks it off. This gets knocked off very beautifully.
Any specific IPL or any IPL?
Eyelight or any of them. We tried looking at LipiFlow. LipiFlow reduced the MMP9 and TNF-alpha. It may help you if you have a patient who has a corneal scar after PRK. Then LipiFlow might help because it reduces these two by 50%. But when you have patient with complaining of chronic pain and it doesn't get altered, for some reason it does very well.
Dr. Shetty, it was nice to combine both scientific and clinical work, and you have always the advantage. I have 3 questions. One of them is comparing, you illustrated very well, comparison between plano convex and biconvex. Has this been studies in a comparative studies between one eye and the other on a clinical setting?
That's what we did, sir, for this. That's what the study.
So you did one eye and the other eye?
Absolutely.
And
I
the
can send
results
you
were
the paper.
different?
Yes, that's in the scientific report. Just 1 week back it came out.
And you know, in surface refractive surgery like TPRK, as well as LASIK, sometimes we have patients who have dry eyes or collagen diseases. Is there any place for this to do as well as do any precautions?
So what I would do is, it's a very nice question. We keep getting this. I'll just show you this image here. That's much more better to explain. From this, you know that the nerves are preserved. One of the challenges with any lenticule procedures or LASIK procedure, why you're worried, is you knock the nerves off, and nerve growth factors are the ones which causes collagenolysis. You know, they secrete unwanted factors because the cut nerves secrete a lot of them. So what is important is, when I see somebody who has collagen vascular disease, I'm concerned about it. Knowing this, you know that smile, this is again getting published, silk is better. But for this patient, instead of doing 100 microns cap, I do 130 microns. When I do 130, I bypass this completely. Then the graph is something like this. And we, again, are publishing this work. You can see here, these are the same patients. One eye silk and the other one is smile. This cut of the nerves. So what I do is 130 is my cap. I go deeper. Once I go deeper, I completely bypass this corneal nerve, so you don't have any effect on it. So we have a good number of patients who are on different therapies, thyroid. For thyroid patients also I do it. I go deeper. Because when you go deeper, you preserve the whole plexus. Not too deep, around 130.
I see. The third question, usually technology starts where it ends. I found deleted it starts with myopia and didn't include hyperopia for correction.
Yeah, they're not.
because
They're very slow
we
on
have
that.
few options.
They're very slow on that. But eventually, sir, when it comes, hyperopia will do very well because I like the profile of it. Sir, when you go back to your cases, your big worrying factor for hyperopia is epithelial getting remodeled, right? Because epithelium in the periphery creates a donut shape, here there is very minimal epithelial remodeling. So a regression of hyperopia is much, much lesser according to me, hypothetically.
Thank you.
Okay. Also the centration, in regards to the centration.
Centration, now you
There's
can
no
mark the
auto-
centration. Like I said, the next generation would be linked to their eye design or one of their, I don't know what they're going to do, but something they're going to link.
So back also to the inflammatory mediators, what about the insulin drops that works on TNF?
Absolutely. What does insulin do is, insulin, I'll go back to that map again. Insulin has a nerve protective factors. So insulin has role in IL-17. That's what it improves the IL-17. That means any patient who complains to you with neuropathic pain or something where you don't, insulin should work well because it is a factor. IL-17 is a classic culprit for all your pain, allergy, environment. And insulin also has an impact on IL-10, which is a good cytokine. It improves IL-10. I remember, teach my students that 10 is like football, Pele, Ronaldo. So always 10 is good. So IL-10 is always good. It is a anti-inflammatory. It's a body's anti-inflammatory. It's like a body produces steroid, body produces IL-10 to fight against it. One IL-10 is equal to all of them. But what happens is inflammation, sometimes IL-10 also gets knocked off. Insulin improves it. Insulin changes the IL-17.
In clinical practice, so if I give insulin, will I not only reduce pain, will I promote healing?
It will promote epithelial healing because IL-17, you saw those cells coming close by?
Yeah.
If I put a drop of IL-17, the cells move away. That video I showed.
Yeah. Have you done any clinical trials like on non-diabetics?
We use Actrapid drops. We are trying to look at concentration. One Indian pharmaceutical company is actually preparing and going to make it in a drops format.
Interesting.
But
So-
it is also important that it is also an epithelial toxic. So sometimes, we have to be careful about it. It can infuse. So I feel it has a role in neuropathic related factors when the epithelium is not healing because it works on the IL-17 pathway. But it may not have a role in scarring and other things because it doesn't have a big role in TNF-alpha.
Okay. So do you complement your post-op regimen with any one of these mediators nowadays? Do you consider it, like a must to prescribe?
There is one patient, yeah.
Litigrap or whatever.
So there are patients who complain with terrible neuropathic pain where I figured out there is nothing which I can find out. Then we have tried it, it works well. And
But it's not routine to all your patients. You
not
don't
not
recommend
routine.
any one of
Because
these
like I said,
treatments.
I can do something simple. I can do an highlight on my patient 3 sittings and it will
Okay,
reduce the
IBL.
same, IPL. IPL can reduce the same setting.
Okay.
There was a pivotal drug called calcicol. It went out of the market. Also, I had some clinical experience. It promoted healing.
Yeah,
in certain-
most of it works on these two, sir. IL-17, IL's thing. I mean, there are many other factors, but this is what I have it, so I can say. Yes.
Thank you for such a nice presentation. I was wondering, cornea is a hydrogel, and in case where we are creating a potential space with the least amount of scar formation, how that potential space closes down or heals over a period of time?
Beautiful question. This is exactly why we have these kind of meetings are so important. Sir, what happens is when you have a plano-convex, when anterior and posterior corneas are not matched, and the space you take out something, what happens is the collapse is not always organized collapse. But when you have something which is anterior and posterior curvature are matched, and you take it somewhere, it closes. But like you said, the cornea there doesn't create a scarring, which is why we are able to see without anything. That space is always empty.
In cases, say for example, with aging, when your endothelial function is compromising and your water
That can be a
content is
fluid.
increasing.
That's why that space could be a potential space for endothelial dysfunction fluid to be there.
So that means theoretically, after age 60, when somebody goes for a cataract surgery, he might take a longer time for healing because potentially
If his endothelium is bad, definitely yes. That is definitely a question. That's why when I do specular for a lot of my patients and I don't do any of these procedures, for them, you're right, PRK is better because you don't have a space and you've created a confocal scar there for anything to happen.
Thank you very much.
We still have 5 minutes, okay, Doctor.
One more question. What is the fix that you used with the Smile or Smile Pro that it's missing in Silk and you wish it's available in Silk?
Smile,
Elite.
like I said, the ergonomically, the beauty of Smile is beautiful. You know, it's quick. Ergonomically, it is good. You know, you don't have the microscope moving from there to here. And you have compensation from your IL master, the cyclotorsion, which I miss here. What I miss from here to there is the ease of dissection. Like I showed you, the peel technique, I mean, with all accomplished surgeons here, you just go in and peel it out. And out of 10, I can do it for 9 of the patients. We can also do it for Smile also if you're experienced, but it doesn't work that way.
You know, in last ACRMS meeting, I attended one session about the Smile Pro. I think also they are
Fast.
adopting fast energy, where I saw that with forceps even they
You
do
can,
like
you can,
elliptical
yeah,
exercise.
you can do it, but you can do it to show it.
Yeah, I think they learned that from
Yes.
from this device. Yeah.
But here is you don't even need to peel. Like we just push it and bring it out. So the learning curve becomes very easy.
Great.
And what's the range of treatment? The maximum?
We have, I mean, they say up to 10 or 11. Nobody does all that now, you know,
And the
because
safest?
so
for
between
regards to the
6 to
bones?
8 depends on. You see, in Asian eyes, where I come from, the cornea is not very thick.
Yes.
And so like I said, if there is a cornea which is a thyroid or a lot of dry eye, I go a little deeper, so that 120, 130, so it bypasses my corneal nerves. So I have that safety thing.
Okay.
With ICL coming in, I think the range of it is a little bit coming shorter.
Interesting. So do you also advocate to do a specular microscopy before subjecting patients with higher degree of correction? I would say like, you know, anything
yeah.
more than, you know, 3 or something.
You can do it.
With regards to that space.
Yeah, I mean, it's a good idea to do it if you have one, but clinically, if you're very good with your slit lamp, you notice there's a change, then you can do it. But I mean, there are people who do it for everybody.
Interesting.
So, yes,
Hi. Thank you again for the excellent
Thank you, sir.
comprehensive talk. My question, because Elita uses low energy, 40 to 100 millijoule, can we say that we can treat wider range of myopia, higher myopia?
No, sir. The range is the same for all the procedures. The reason is they use lower energies, but the amount of lenticule per diopter taken, which uses some kind of Muller-Lens formulas thing, is more or less the same. It is not more or less compared to the Smile.
I see. Again, you said because of the biconvexity of the lenticule, you said almost we can just pull it. We don't need to do any separation.
It's more of the energy, sir.
Can we take it as granted, or this is only in your hand?
In fact, I would say that you do the first 100 eyes, and I get a lot of people from Taiwan, Korea, and all of them. I tell them, do the first 100 eyes, smooth dissection, and then after the 101st eye, try it, and you'll never go back to the original one. So it's not difficult. It's just that, yeah.
Thank you for the organizer and for the Dr. Shetty for the presentation. Just a quick comment or suggestion for the docking and the suction ring. I'm noticing it is almost like the intralace, and the experience with the intralace was not that pleasant for the patient side. They have some pain and squeezing in compared with other platform. Don't know if it will be able to modify that.
One big challenge I had in the beginning was I forgot one more thing is the suction on silk is smile is lesser so that you don't get subconjunctival hemorrhage. But the fear is that even today, after 14 years, I still get a lot of suction losses. And here I don't get it. So we have to look at the plus and the minus. So what I do is I put a drop of alpha-gen drop, 1 drop, so that it reduces the subconjunctival hemorrhage. That's one. And the second is that also has some role in making them quite comfortable. Like we also have a very small eyes, and I go to Taiwan and on those places, Korea, and those doctors come, so they also have smaller eyes. So they said that they have not had any major issues so far. And one good thing, sir, is it's good suction. That comfort zone you have, that I will not lose suction, is very pleasing to a surgeon after doing so many years of smile. When I'm always worried, my heart is always beating, especially when they start moving around.
You've had no suction losses during your 3,000 cases?
No. One we had.
Okay. Maybe that was the redo.
No, that was a different one. That one we had.
I have a question regarding, you tend to go posterior and compromise corneas. Is it because only for nerves or because of populations of keratocytes?
No, it's only for the nerves. Only for the cornea. Only for people like you said, collagen vascular disease, thyroid, and these kind of patients, dry eye patients.
Because they are less populated posteriorly than anteriorly.
They are, but what happens is when you go deeper, the deeper cornea is what biomechanically strength is. When we did some mathematical analysis of the thing, as you go deeper, your biomechanics becomes weaker. So being on the anterior is always better.
What was that? I thought the anterior cornea was stronger.
It is stronger, but for some reason, because it remodels or whatever, our studies showed that the biomechanics getting weaker as we go deeper.
Wow.
So that's why we were very, very hesitant to go deep. And that was not with silk, it was done with smile. And we have submitted it for a thing. It does really good for the nerves. You get complete nerve regeneration. Patients have no, tear metrics get better, no biomarkers, completely normal. And this works wonderfully well for thyroid and all those patients. But you have to have a strong cornea.
Okay, last question, Rohit.
Doctor, we are really delighted to have you here.
Thank you.
Comparing those two.
I've not had the chance to work with Clear, but if you look at the profile, they're very similar. They also have it. It's a little longer. And whatever I've seen that machines in wet lab, it's still like a microkeratome. You have to hold it. And there is still amount of that factor which is there. But the software of that is pretty amazing. And they are now connecting it to Galilei. Galilei. So they are going to have a thing. So one thing about which I feel J&J should be doing is to quickly connect it to one of the diagnostics. They have an eye design. They could easily do it. And hopefully that's going to happen.
Okay, so the generals here have given me orders that we have to move on.
He has one question.
Doctor, regarding the small eyes, do you apply the suction ring without speculum?
You can do it without specs.
Is it safe without
it is safe.
the
It's
fear
very,
of
very
suction,
strong.
loss of suction?
Very strong.
Okay, another question, small question. Regarding the patients around the age of 40, I mean 40, 42, 43, something like this, you mentioned that you can create a depth of focus for those type because of this.
I don't create it. It's already there with the profile. Okay. So it is like it's like a collateral benefit. This is what I believe.
Do you stick to the nomogram?
It's just the same nomogram. I don't undercorrect them.
Because the nomogram sometimes or not sometimes, nomogram is overcorrect about 0.75.
Just stick to the same nomogram. We did not change anything because we did not create any monovision, anything. It's just plano thing. And that itself was giving us good results. I mean,
Thank you.
you can also try, and if he's doing it, then we should all write it up together.
Thank you.
Okay, so our next talk now is how to be an expert in managing challenging cell cases, insights and best practices. No, you continue.
Somebody can just. This is second talk, if you can just put it. Second talk. So there is a lot of small repetition, so I will just skip wherever there is repetition. This is to be an expert. That's not about expert. It's just about bringing mindfulness into your practice. So mindfulness, when I say this is what I teach my students, is when we go to OT, we have so many things are in our head. You know, our conference, travel. So most of the time, we don't see what is in our environment. So being present in the environment is probably what mindfulness is. And that is important because we miss out all these things. What secretion does, how much pressure you do. If you're not mindfully present with you and your machine and the patient, you'll not pick up any of these things. According to me, 99% of the patients who are unhappy is because one of the factors has been missed. And this is what I believe in, and I'm sure if you pick this up and you can start looking in your practice, you'll understand after my talk. For example, a simple alignment. See, some people have a very big nose. This, again, small eyes, big nose. And, you know, I had to tilt a little bit. Now you have a cyclotorsion compensation. Because if you don't, that will come in between, and what will happen is it will keep hitting here, and then there's a chance that if the patient moves his head, he may end up in a suction loss. This is one of my favorite talks. I use Parakin. It's pro-Parakin in India. It's a thing. This happens. This people put, somebody is without you. It happens in cataract also. They just keep putting drops. So that's what I said. This is, I mean, you may say, how does this, a simple drop have an impact in your practice? From a clinician, it doesn't matter at all. From a biologist, this is probably the most important thing. We have done a lot of work on this because if you look at two epithelial maps, Parakin on that and this will differ. Because in scenario 1 is a healthy eye. This one is a healthy eye. This is a dry eye. If you put a Parakin on a dry eye patient and you do a surgery, cataract, LASIK, PRK, whatever, you'll completely get a different picture because all the factors I showed you here, Parakin has BAK. I mean, at least the one which we use. And there are enough papers on it. So the first important thing in practice when you want to be an expert is mindful and do not use too much of this. So we did a study. When you do you can see the difference of NT, but look at the biomarkers. Every single marker is high in these kind of patients down here. And we found that this was not with silk, it was older paper. You create a lot of T-cell response more in patients because you create more challenges. So a simple misuse or abuse of Parakin is one of the first important thing, and be mindful about it because it can change the biology a lot. That's the first thing. Use enough for you to do the surgery, but be very careful about it. This is the first and the most important thing in your practice, because when you, I have noticed it all the time. And the second is when you start doing it, there is this here, the machine is always kept in this position and the patient is here. So what happens is, if you play this, look at the distance, and it's a very slow one. By the time this comes in, you already have a dry spot here. And you are not noticed it. And that's why it's very important that I tell you always bring it as close to the patient and look at the distance. Enough for me, that this is the distance which is enough for me. There's no dry spots. And look at the difference between that and this. It's a very small thing. Look at, there's no dry spots at all. Why is it important? Because when you are operating on a dry spots, your laser energy is different and you will struggle. You'll never cut through. And exactly the same thing. But this silk, it's important that these other things, see, it's always kept in this position because it goes back and it's very slow. Look at how slow it is. By the time it touches the eye, you will have full area will be dry there, which we have forgotten. And one thing which we see is, when you see, once you customize the energies and other things, that's how you can change the energies. You don't play too much with it, but there is something which you can do. The third thing is, you are in that stress state where there is too much of fluid between your optics and this. There's too much of fluid. Remember one thing, the laser has to pass through air, the optics of the lens, and then there is a fluid out there, and then it goes to the cornea. So when it does that, it ends up in a lot of these very tough dissection. These are not very, very nice things when you're a beginner, because look at the struggle. I mean, here it's okay, but there is a lot of struggle which creates it. And when you struggle, what happens? Your Bowman's becomes wrinkled. And this is the most important thing is, remember that the more you struggle, the more the wrinkles it is. The second problem is, be very mindful about when your patient is under your microscope, just look at these mebum secretions. These are not very good. You may dry it off. Mebum secretions are the ones which actually gets into your meniscal fluid here, which is here. And laser through oil doesn't dissipate well. So you can have these black spots. And these black spots becomes a challenge because you have to then, it is a struggle. And every black spot is a small micro trauma to the cornea, and healing is going to be completely different. These are all experienced surgeons, they can do it, but it's not good. Because when you have black spots, when you dissect those black spots, wherever you're dissected, those keratocytes become myofibroblasts. And that area, it scatters light. You can't see it on your slit lamp. That's why, many times we don't believe in them. This is what I wanted to say. And you get this, look at the interface haze here. And look at the amount of thing. So the two important things, paracrine again causes dryness and changes. Second, the amount of how much you keep your spacing. So when you do it, always keep it enough for you to just go in quickly. And the third factor is the mebum. I think mebum secretion is very important. So what do I do when I see a black spot? This is also very mindful, because when I see a black spot, I change my steroid regimen. So if I see a black spot and I've struggled, I tell my staff that I need every hourly steroid for the first day. Why do I need every hourly steroid? Is because I want to break this nexus. Your keratocytes are activated immediately. If I want to knock that keratocytes off, I need to get them on RD steroids. So my steroid regimen changes the minute my tactile sensation is different. So mindful surgeon means your tactile sensation has to tell you, it's like a loop, that there is something not right with this, because the minute you have a tough dissection, the picture comes in my brain that I have angry keratocytes. And how do I make an angry keratocytes less angry? By giving steroids for the first day. And I stop it. So everything happens, because that is why we are able to reach that 20/20 vision, not because of skill or laser. It's about understanding the biology. And you tell your patient that you will heal a little slowly, because he would expect there'll be some amount of edema, and this is what I mentioned about. And this is a spection, and again, my assistant sometimes keeps pushing. When you increase the speculum, the challenge is that you increase the mebum. There's a mebum there, and the mebum is going to be between your glass plate and this. And what does the mebum do? Is oil. The mebum is filled with your, mebum has both unsaturated and saturated fatty acids. And that is not, again, what I mentioned. And mebum also has problem with lamellar keratitis, because if we took this mebum and analyzed for it, it's filled with 100 times more MMP9 and IL-6 than your TFL. That means it's a cocktail of MMP9. It's a fluid containing MMP9. That means anything which goes inside. So when you have more mebum, if you keep washing your eyes, or somebody has a tendency to go into the pocket and wash, that has to be avoided, because you are taking an MMP9 fluid to the pocket. So that is something which we have to be careful about. So mebum is one of my favorite things in ophthalmology, in ocular surface, because it tells a lot. It's like a volcano. So every time, a simple end of my day, if I see this picture, I know this is going to be a challenge, because what I see is a bad meibomian glands, the T cells, these are dendritic cells, and of course the biomarkers are heavy. And what do I see is a bad dry spots, which is difficult for us to handle. And just what I mentioned about me. So what I do is, I start them on post-operative regimen. For me, when I see more mebum, is completely different. So what I'm telling is, I don't have one size fit all post-op regimen. It is mindfully driven by every single thing which happens with the patient. For example, if I see more mebum secretions, I change the prednisone, make it hourly or for the first 2 days. These patients need cyclosporin, and these patients would need immunomodulators, because you are worried about how they would probably change the healing response. So mebum is about health of your ocular surface. Mebum is about healing. So if you have more of it, that means you have to be mindful about it. And this is a very important thing. When you are doing the surgery, an expert would do one docking and he will be over. In SMILE also, we have done many times docking, but in silk, we have to understand that it increases the intraocular pressure a little more. So if you're done, when you're learning, you always tend to dock once or twice. We all have that mindset, doesn't matter, we keep doing. But remember one thing, it is not an excimer laser here. When you increase the pressure, you're increasing the changing a lot of aqueous currents, a lot of fluids. When you repeat suction, what happens is, we did human globe experiments. We created suction, and the hydration of cornea was different. So when you have a hydration of a cornea which is different, the laser is not going to go through the same way as a virgin first attempt cornea. So remember one thing, SMILE, the IOP raise is not so high. And so you can do 2 suctions and still wait for some time. Here, after 2 suctions, if you're not got it right or you're not happy with it, wait for some time or do the other eye. because your laser spots will be varied. When you have varied laser spots, you get different dissection. And when you have a different dissection, you will end up in a challenge, and sometimes you may end up not being very happy with it. So this is what happens with the beginners. When you're beginning in your journey, you will always find a suction a little challenging initially. So do not jump and wait for some time. And or do the other eye. If you're doing the right eye, do the left eye. And this is what we get. This is what we get when you do the third suction. You would have not waited. You see so much of fluid here. And the patient complains that he's seeing through a glass. When patient comes to you on any lenticular procedure and he says, I'm seeing as though seeing through a glass, please remember this beautiful confocal images. I've been working on confocal for the last 21 years now. It's been, now unfortunately they stopped manufacturing. The Heidelberg stopped manufacturing, but such a beautiful tool. Anything the patient says, you go back, no, you get something out of it. And this is the patient. All you need to do in this patient is increase steroids. The edema will disappear. And, or you start immediately. So, but remember that you are dealing with a different activated keratocyte. This is what I tell my patient, you will get better, but this is how it changes. So what do I do in this? I perform the other eye first. If the right eye has more suction loss, or wait for 10 minutes. If it's the left eye, wait for 10 minutes. And also please look at, I'm not that I'm a big fan of steroids, it's just that I understand what is happening in the confocal stage. If you treat them in the beginning, you block the tsunami. So 4 points now. The importance of paracaine and its importance of healing, the role of mebum, role of multiple suctions attempts, because you are dealing with the stronger IOP. The IOP is much higher than the other competitors. And it's little longer, like you mentioned, so we have to be a little careful. And when you are starting the procedures, one important thing is, do not enter the eye till you have focused on your microscope. It's not a big tip, but the microscope has to clearly delineate the edge of the lenticule. Because that is very, because sometimes, you know, it's little defocus. We think that we can go in, but you will not. You will enter the posterior plane. And there are times when you're treating a -2 and you don't get the lenticule edge. So one of the tips is that I push it, just push it, make it like a bunch, and you take it out. If I just play this again, it works very well. This is small powered. I push it, so it becomes like it gets folded. That becomes, it gets more meat in it. This is what we do. One important thing is stronger biomechanical eyes behave differently. If you have a biomechanics machine, please use it here. It's wonderful. I mean, for example, this is not a keratoconic. It's but it's the biomechanics is a little weaker. And look at this. Look at how strong the biomechanics is. So it gives you an idea about how the patient is going to behave when you're dissecting. Strong eyes have, so don't, if you already kept your energy as 40, sometimes they tell you, oh, you can go to 38, and suddenly you get a black spot. Because if you kept the energy as low as 40, it may work well for these. Most of our corneas belong to this. Asian, Middle Eastern corneas are in this range. This is very tough eyes. They're very strong eyes. And strong eyes, sometimes you've gone very low energies, you will have some. So just be aware that when you have a tougher dissection, your quality of vision is not going to be great. So explain to the patient about it. What I do is, these kind of patients, see, it's 131. Somewhere here is where we get. When I see this, I tell my patient, see, your eyes are very strong. I would like to do, I give them an option. You want very quick vision, I can do an excimer laser, but it will take a little time. And invariably, it follows this trend. Because tough dissection has a different confocal compared to there's no change in the keratocytes. I can change. For example, if I'm treating -4, my corneal thickness is 580, and I have a biomechanics of 131, which is like rock. What I do is I tell my staff what is the energy I have kept. They've kept it as 40 or something. I keep it as 42 because I don't want it to be too heroic here to do it on a low thing. And sometimes you may get a very bad black spot on it. So it is important that biomechanics also has a very important role. And if you have a Corvus, this is a fantastic tool to use. It is something to be used. And this is one of the most common problem is you miss the anterior and posterior dissection, and you're gone posteriorly into the, and you keep digging. So instead of digging, one of the thing is, if you use, if you can see here, this is the edge, and this we have gone into the posterior, and if you delineate it, and if you can gently go in, it's not so difficult, and it's probably quite easy to. Only thing is you may end up in some amount of Bowman's wrinkle, which I've already explained. I can skip this one. So biomechanics helps you to optimize your energies. For example, this is my old energy settings, which was 45. Now, if I'm using 40, sometimes if you use more energy than what is necessary, you can get a sticky lenticule. Sticky lenticule is where you actually have a lenticule which is already dissected. That happens in very thin, biomechanically thinner cornea. So that is something we have to be aware of. So this is what we call BIOLEX, biomechanical integration into lenticular extraction. I use this in all my patients. I used to counsel my patients. For example, it's a very strong eye. I tell my patients, see, it's going to be slow recovery. In my country, I mean, I'm sure it's everywhere, you explain to a patient something and something happens, he takes it in a much better way than not explaining and explaining him later. So I always tell him this is how it is. And sometimes I've told him no also, because there's a photographer who wanted to go and watch some the Great Crossing, and he wanted very good vision. I said it's not going to work because he had a mechanic 600 cornea. So I did a Wavelight Plus for him. So there are times you have to be very honest with them. So this is I have explained. This is interesting. I use something called as a collagen imaging. This is what we built. It gives you, it's a polarization OCT principle. This is the collagen mapping. It uses the birefringes. Just for the sake here, strong shades of dark blue means you have good collagen in the center. These are your anchoring fibers. And this, look at the collagen is very good, decent, not so decent. You use the same energies on your patients. Look at the keratocytes thing. When you have a very tough collagen, your collagen keratocytes completely behaves different compared to these two. And that's why this is a slower recovery. That's one of the reasons when you have a tougher corneas, tougher dissections, think about increasing steroids, because you will change the healing pattern of a keratocytes. And this is what is important. And I have given this already about how you have to use what is the pattern of steroids. So be mindful not to have one post-op regimen for every patient. It might have worked very well during your LASIK days, but in lenticules, according to me, it doesn't work because every case is going to be different. And we mentioned about the corneal nerves, and this is what I mentioned. The ion channels are in your epithelium, and this is what makes you nociception. When I spoke about this, Alcon is coming out with the drop, which is going to increase the TPRV8. What does it do is when you use that drops, you get a menthol-like feeling. When you eat menthol, you get that fresh feeling. This is what it does. And what gives you an unhappy feeling when you go to a AC or when you get that irritation. This is the TPRV1. And these are all the channels which is very important, because this is what makes our patient unhappy. they're unhappy with their 20 by 20, but after some time even that gets better. But this is nociception is where it is. Nociception is feeling of, they're constantly blinking, they have tears, but they're unhappy. Look at this light, it waters. You get these patients who come to you and say that, after cataract surgery, I wash my eyes and it hurts. This is this. Yes, because it reduces the sensation. And I use this picture because the ion channels is just how it allows the flow of solutes, basically. And this is one of my fellows drew this. This is how it is. Every epithelial cell has one of this out there. And this is TPR-VM8. So what we did was, we looked at the nociceptive, there's a questionnaire for nociception. And you see that LASIK PRK, this is after 1 year, still have 36% of them have nociceptive related issues. They don't come and tell you, but they have it. Like, they can't sit in an AC car. They can't go out. When somebody is talking loudly, the eye starts watering. It's very classic, and you believe that is nothing. The patient is not normal. That's because the drive of nociception, the sound waves can also trigger that nociceptive factors. And we have published this work in dry eye. So, it is necessary to keep the nerves healthy, not just for dry eye. I just don't want to talk about dry eye. It's about healing. It's about epithelium. It's about regression. It's about how you maintain the, how you take care of the keratocytes. And this part I have already explained. So biological cleansing. So coming to this, what I do in my patients, this is the most important thing, is how I assess, do I need to pre-treat them and how do I change it? I have a simple 5-thing questionnaire. The T-butt, the meibomian glands, is the patient contact lens intolerant? And is the OSDI high? And if the 2 of them are present, then I pre-treat them with cyclosporin. Because for me, in my practice, I don't want my patient coming back again and again, bothering me and my staff that they have something which irritation or something which I could have avoided. And IPL is one of the things which I do. And if there's more than 3 factors there, then I get into the IPL-based therapy, because this helps me to stabilize this. And I've told you why it does it, because it takes care of a lot of those biomarkers. So this is what I do, a simple thing in my practice, and this worked well. It's yet to be published, but this works well in many other population also. So how does it help me? It modulates nerve and ocular immunology. It creates less effect of the keratocytes, so that edema, what you get, gets better. The quality of vision is better. It stabilizes the ion channels. Nociception is better. Less active keratocytes means less scatter, so the day 1 vision is better. And late onset remodeling goes off if I use cyclosporin, because there's a nice study which has come out is once the late onset remodeling goes off, I don't have to worry about regression and other things. And it's just a holistic approach. This is what it gives me. And it helps, and apart from all the other things what I mentioned. I end my talk with this important case. This is a 21-year-old girl who underwent Kleck's silk procedure. And she complains that what I treated her was -1.5 diopters. And after 1 month, 2 months, she comes back and says that she's got the same power, very unhappy with what has happened because she still can't see. So one thing is, if you look at the Tracy, she has a 0.8. This is the cornea, which is near normal. Look at the lens. This is a very, very common thing we see. This is a pseudo-accommodation happening in this patient. And she had a convergence. We do an orthoptics evaluation. She has a convergence insufficiency. These are all the evaluations we did. And We did some home-based therapy. This is a paper which we published. And after this home-based therapy, this was an accommodation access. And these are all the therapies we did. Yeah, and you can see that it's completely become normal from there to here. Very common problem. They come to you saying that the power has come back and they push you to do a recorrection. They think that there is some nomogram issues. So if you have an eye trace, please get this eye trace done. It will pick up something so powerful. I just showed my patient, I have made it perfect. You are creating this. This is your convergence or accommodative access. And if you give them the therapy, this is just 3 weeks therapy. No, we give them orthoptics, all this different negative lens, card, accommodative flippers. I call them to the hospital. I tell them, you need physiotherapy for the eye. And we have some department which does intensive therapies for them. And now our power has gone back to 0. Otherwise, you would push yourself to do a surgery for them. Any questions on any of the things I discussed so far?
Sometimes we use on the sponge and put it on the conj rather than put it on the cornea, and this avoids epithelial changes. In addition, sometimes we always wash the surface with BSS prior to docking or doing lasers. I have a question, 2 questions. Regarding PRIT 40, I noticed that you use it hourly for 2 days.
1 day, first day.
Is this too frequent or it is geared for the severity?
I only give for out of 100, maybe 5 or 6 of those people where 3 condition I use when I see that I have a very tough dissection and there were a lot of micro black spots. I don't use for everybody. It's just for those few patients.
I see. And sometimes we encounter patients after, especially PRK. They have excellent vision, 4 weeks past, but they have photophobia. Is this under nociceptive?
Yeah, absolutely.
Not because of other biological...
No. Nociception is very, very complex problem which ophthalmologists are just trying to understand now. Because for us, everything is driven by dry eye. It is not dry eye, it's a nociception. See, to be very specific, that there is a factor called in one of the ion channels called TPRV-M1. These are the factors which makes you hyper-exaggerated to everything, to light. One of the reasons is the negative and positive dysphotopsias. People are blaming too much on the lens. Many times it's driven by the ocular surface itself.
And this appears after use of steroids in 2 or 3 months.
Absolutely. Steroid doesn't change much of nociception. Cyclosporin will do, and you should try the IPL therapies for them because it reduces IL-17, which is a driver of ion channels.
And I noticed your imaging with OCTs. You use Pentacam, right?
Yes.
We use other machines, but doesn't have this very beautiful linear...
If you use MS39, if you use their applanation mode, you can get it.
I see. Okay. That's good trick. Thank you.
Dr. Abdullah?
Thank you, Dr. Shetty. With the nociception, do you have anything to anticipate this patient will have these symptoms? Because as you said, we always relate it to the dry eyes. Even you don't believe it's a dry eyes. We examine the patient, is very nice, good tear film, everything, but the patient is not happy, even like 1 year, 2 years post-refractive surgery. Anything that you can exclude those patients or, take them from your...
Absolutely. Brilliant question, sir. 3 important things which helps is, somebody asked me the same question. All your biomarker is researchy because you are an academic institute. What about somebody in a clinic? And how does he? One, If he's a contact lens intolerant and he's come to you saying that he's not happy with his contact lenses and he wants to get a surgery done, he's a red flag. So always go deeper in those patients in terms of, or you pre-treat them by IPL, cyclosporin, Lipiflow, one of them, because you dampen the risk. They're always high. And the second is, these contact lens intolerant patients, give him an OSDI scoring. If the scoring is more than 35, you know you're already in that edge of nociception out there. The second, you look at the epithelial map of this patient. The epithelial map has got many colors in it. Red, green, and all those colors. You know, otherwise it's always uniform. Either it's green or it's yellow. More the colors of a flag means that you are creating when you have more colors, it means that there is an immunology of the ocular surface is at stress. That's the second thing. And nociception always is driven by the quality of your lipid secretions. And if your meibomian gland dropouts is more than 30 to 40%. And if you look at 3, that means you are very close to identifying somebody who will have this. And this is not just for lenticule, this is for cataract or any surgery you do. And in fact, it works the same way for your glaucoma surgery because same nociceptive factors does a different role there of fibrosis. You do a trab and it creates fibrosis.
Also, the fluorescein staining and the tear breakup time.
It also, of course, those they're there, but
it's always reduced.
Because what happens is a lot of us in this environment when they work, anyway the T-but is low because of inadequate blinking. But these 3 factors were directly linked to the post-op nociception.
You've mentioned so much focus on the eye and ocular treatment. But for my practice, I've had my fingers burnt from a number of cases. Maybe I'll just share with the audience and with you. I had 2 ladies, healthy ladies, seemed, healthy and right weight, and they had very poor healing post-operatively. And I did all the tricks and the lubrications and the stuff and the cyclosporin and the autologous serum. And then out of, desperation, I asked her, did you have any surgery done before? And both ladies had bariatric surgery done, sleeving. And so when I ordered for a vitamin profile, they had almost 0 vitamin D.
Yeah.
Just giving them vitamin D and correcting this, within 1 week, they're both healed. So this is something, systemic nutrition is also plays a role.
Absolutely. Brilliant point you brought in. And from an immunology point of view, from what Sir said about vitamin D, if I take a vitamin D injection, it doesn't remove MMP9's IL-6, it doesn't do anything. IL-10 goes up 100 times more. So what it does is, it doesn't knock off, it is not an anti-inflammatory, it makes a pro-inflammatory. It's not an anti-inflammatory effect. It improves it doesn't do anything on the pro-inflammatory, It will improve the anti-inflammatory effect of IL-10. The amount of it going up is so beautiful, such beautiful biology happens. Like you said, minute the IL-10 goes up, it suddenly knocks off all the other, it's like one policeman taking care of 10 thieves. It's one is enough to knock. And what increases is, like rightly you said, the vitamin D.
Also, I just want to mention one unfortunate experience I had. I had a series of cases, 2 or 3, of toxic corneal keratopathy, toxic keratopathy, in a number of cases. So nothing has really changed in my practice. And then when I revised, I found that when this new eye drop, the Lumify, that brightens the eye, I started using those in my post-femto LASIK patients. Sometimes their eyes are red immediately post-operatively, so just putting 1 drop, the patient at least, returns back home, not in a very scary manner. So, and then I extended my drops using in PRK. I think, and that was the reason. Lumify has benzyl chromium chloride 60 times more than Alphagan.
Yes.
And more than your regular eye drops. And that's why Alphagan moved away from benzyl chromium chloride. And this can be very toxic to the epithelium and to maybe...
Yeah, absolutely. Absolutely. Because what they do is they trigger off a response which has a poorer healing in it. So one important thing from today's, I mean, I'm sure all of your accomplished surgeons you can learn is, one important take-home point is, for everything happening, like how you mentioned, remember there's a biology behind it. And if you start digging into it, everything becomes much, much more clearer in your practice. And for example, I'll just show one image of this. If you can. This is a biology between those 1 millimeter spots, between every millimeter spot, there's a huge amount of biology which goes in healing. The TGF pathways, or this is the exact pathway which losartan will work if there is a scarring, basically. So that I just wanted to bring this up because even every single spot has own biology there. And you mentioned about BAK. The BAK increases this response, and when it comes from here to here, it creates pro-inflammatory scar-forming things, and that's what it creates the scar. So these two factors. Yeah, that's how it works there.
Not only vitamin D, but even calcium metabolism in cases of parathyroid dysfunction.
Yes, absolutely.
And I also have one experience when a patient who have antiprolactin, who has a very delayed healing, extended 2 months. So systemic, yes.
And what happens is people who are on any of you mentioned rightly the hormonal imbalances, that works on this pathway. The lot of this, it's like an electric circuit. One button goes to multiple things. Any one button can tilt the balance.
So it's very interesting for our group just to know how many of the audience have tried to do this keratorefractive lenticule extraction. Can you please show hands? Okay, so as you can see here, our number is low because we're still doing this laser vision correction, right? But we would like to know from you, how do you select your patients? I'm sure you haven't stopped doing laser vision correction, that's one thing, but regardless of the platform that you are using, whether it's a Smile or Silk, we would love really to know, when do you select patients for the cheaper, I would say, type of refractive procedure, laser vision correction, or when you're going to subject them to this sophisticated. I believe that there is a future for this, and it may replace the laser vision correction in the coming years with all the competition in the market. But really, we need to be considerable when we select our patients as a beginner in this group. So that's the first question. And then the second one, it seems
I'll answer the first question.
Yeah.
So, the reason I did not put that criteria is the same as LASIK. The only difference is whether that's the only thing. And the second is the learning curve for already an accomplished surgeon here is very minimal. It's in the mind that it is a different surgery. Of course, I see when you have a very tougher dissection, difficult ones, you have, but when it comes to silk, it's quite smooth. So there is no criteria which is different from what I would not do LASIK, I would not do Smile or Silk on that. So I'll do exactly the same criteria follows with me. The only difference is the first 100 cases, don't be heroic in doing on very low energies. Don't be heroic in picking up very strong corneas. Be careful in choosing not 500 corneas, 600 corneas. So that's what I would recommend, because I'm sure experts can do all that very well. But first 100 cases, be very careful about it. Otherwise, I have no different criteria for selecting this patient, apart from, of course, the money factor it's more than 50% more charges.
But do you think that the patients with higher astigmatism will behave better when you
Yes,
the
up to -5, we have done it. Yes.
Right? So that's one of the plus criteria.
And biomechanically, this is better.
Better for the highest cylinder. And then the other thing is that it seems that listening to you, we've done just a Smile, so I don't have any experience in doing the Silk, but It seems that the interface fluid syndrome, the lamellar keratitis are one of the complications
Very
you're still
rare.
seeing. It's
Very
not as
rare.
our
That's
LASIK
not
patients?
there.
Okay.
And in our geographical, even a different type of an environment, I feel smile or silk is the way to go.
Interesting. And then the last one is that you've done a couple of cases over the past 6 years. Any ectasia?
No. I have had ectasia since smile also, maybe 2 or 3. But one of the ectasias I found, because I preserved the lenticule and we found a genetic defect in that patient pre-existing. So it was a lysyl oxidase thing. That's what I am, hopefully next year, if I'm here, I'll show the gene therapy. We are starting gene therapy for this year. We're injecting adenoviral vector with genes to improve the collagen synthesis for keratoconus.
Okay, thank you.
What was your second question, ma'am?
That was the second question. Smile extra, maybe. In the future.
Dr. Maan, can I have a comment? I want to ask you, Dr. Rohit, if you have pupil measurement as a part of your basic assessment in doing refractive surgery, especially optical zone and silk is smaller than the... So if the mesopic or the scotopic are large, would you change your decision?
Yeah, we can enlarge the zone. Some people have gone up to 7 millimeters also. Okay. But I keep it at 6 because fortunately a lot of our pupils are smaller. But like I said, this is only for our population. Maybe
so even in larger mesopic?
Even if it's a very big, it's a very good question. If it's a very big pupil, I do wavefront guided procedures because I don't want to have a large angle kappa. I don't want to take a risk here.
The second question is about, I mean, if you come across like rare complications like epithelial ingrowth, or it has been reported to you.
Yes.
I know it's rare to happen, but I believe it's going to be maybe more challenging to manage it in maybe doing a lenticule extraction. If you ever came across or whatever
I've had
advices in managing such.
I have one ingrowth in smile, not with this. It happens because when you are very not careful with your incision edge and you're dissecting, you may have some epithelium growing. So when you have even a small epithelial loosening, it's best to manually remove it and put a bandage contact lens. But if you have an ingrowth, then with one of the same spatula, you can go take it out. People have washed it with diluted alcohol also inside. I don't think it's any different. The people have also done a circle software and made a flap and removed the thing also. But like I said, I have not seen it. I don't think anybody has seen this in silk yet. But I'm sure it will happen. It's not that it will not happen. It's just that more and more people start doing it. It will. But be careful with how the epithelium is. Yeah. Yes, sir.
Just. Yeah, can I give just a comment about the sleeve surgery? Also, in sleeve surgery or gastric bypass, we have vitamin A deficiency, which can cause even dry eye. Yes. Also, B1, B6, B12 deficiency.
Multiple, everything.
Yeah, the inflammatory healing.
Yes.
So it's really important to know that.
Mix of everything, yes.
Yeah, just a technical question. Have you noticed any difference if you treat, for example, -4 in a 46 diopter cornea or like 40 diopter cornea? Does the cornea behave differently in bioconvex lenticule?
We didn't go less than 40, but I think we did around 40, 40.8 or something. There were only 3 of them patients, but I did not see them anything different than what I would have, which is different. So, but they were just the same as the other patients.
Great. And how much flattening do you expect? For example, if you treat -4, do you expect 4 diopters?
It
or
depends.
less?
Sometimes it also depends on biomechanically state of the eye, how much the cornea would remodel itself. But something similar to LASIK, but the way the gradation is going to be different. Gradient means how the cornea in the center and the periphery is the gradient difference. You see a stark difference in an examer. The center is flat, the periphery is steep. Here the gradient is much lesser, much tighter. That means if you have a center of 41, the periphery would be around 41.8 or 41.6. So that will be a small difference.
Okay, one more last comment is by understanding the neurocascade, do you believe that smile or lenticule extraction in general will replace LASIK with time? because you are cutting nerves with flap.
especially in an environment we all come from, which is inflamed with the weather and other things, preserving nerves should be our main interest. You know, nerves are not just for dryness. Nerves have multiple other functions, and I think we should look at this. That's my first goal.
It might not replace it for enhancements. Enhancements, you still need it.
Any post-graft cases you did? Post-graft myopic cases?
No, sir, we have not done.
And you said that the only difference between Gear 2 is financial ability for patients to select, right?
That's one of the major ones. But of course, there are, like he said, good point, larger pupils, large angle kappa. Patients, I also don't do on patients who are very stressed about surgery, because I'm worried about losing suction sometimes. So there are some very unrealistic patients we get, so I don't do it on them.
There are two sets of patients who are good socioeconomic and the other. This is not biased of selecting patients that will reflect on the outcome, no?
I don't think so. Sir, what has really in my practice have made a huge impact on the outcome is the inherent immunological status of your eye. You know, that has a huge bearing on the outcome in terms of day 1 to 6 months, about how they feel. That's why I use the word biological cleansing, is to take care of them both intraoperative, preoperative, and postoperatively.
Thank you, Doctor. Thank you, Doctor, for this beautiful presentation. I'm very happy that you mentioned the nociceptors and the neuroadaptation, because I feel we're not talking enough about it in cases of dry eye, and especially as the chronicity becomes longer, treating it becomes more difficult. This is with neuroadaptation. Yes. And I'm also very happy that you mentioned, Dr. Maad, the cases that you dealt with, especially with the hormonal imbalance cases and the metabolic issues that happen and how it affects the cornea, because we're all managing similar cases, and this is exactly what we encountered. When you dig in the history, you discover that there's something else systemically that's going on. I believe lenticular extraction procedures, you're getting the best of both worlds. So you're getting the benefits of LASIK with lesser complications, or removing the complications that come with the folds. You mentioned, Doctor, the depth of your lenticle, that in cases where you have a little bit more dryness, that you would go a little bit deeper.
120 or 130 microns.
Yes. So why not adapt this to all of your cases, since the modulation and everything related to the neuronal plexus is less affected?
See, I was funded a study by Zeiss, where one eye I had to do a 140 depth, the other eye I had to do a 100 microns depth. And we did around 100 odd eyes of these patients. We had to measure more than 100 endpoint metrics, including biomarkers, corneal nerves, nerve factors, proteomics, everything. Everything was good in an eye which I gone deeper, but consistently one thing which was not good is the amount of biomechanical imbalances it created. It changed around 22% less, more imbalance biomechanically than the eye which had 100. So I would only reserve it for people where I'm worried about dryness or something, not for everybody. That is only that. Based on that paper, this is my answer.
Okay, thank you very much.
Okay, thank you so much. I think we'll stop here because we have prayer and lunch and have a very tight schedule. If you can all come, please, and we'll take a group photo. Thank you so much. It was a wonderful talk. And we'll... Dr. Samar, Dr. Ali, Dr. Ahmed, please. If you can take a group photo.
फुल है ना बैटरी नहीं ना फुल इसको लगाना पड़ेगा तो है नवी बैटरी
About the patient selection criteria, it's usually like all refractive procedure, except here that you cannot do the hyperope, so no treatment for hyperopia or presbyopia, and I would eliminate optimal outcomes. Communication with the patient, I think it's one of the most important issues, that clear communication to build up the trust and appreciate the expectation of the patient. So how to explain silk as it's a new procedure. Most of the patient when they come to the clinic, what is silk? Is it a safe procedure? Why should we do it? If it is a new procedure, is it like have good outcome and these questions? So we explain it to the patient. Some of the patient already know the Femtosmile, so we explain it like it's similar to the Femtosmile with some changes. We addressing the common fears of the patient. Is there like pain? How about the recovery after the procedure and safety of the procedure? Usually when emphasizing that there is no flap with a natural healing, it's one of the things that convince the patient to go for silk, and usually using the brochures and other like patient experience would help in convincing patient to go for the procedure. So in our population, it's like quarter of the population is having myopia, around 12% hyperope, and around 9.5% having astigmatism or with myopia. So what do we need to do for the surgical preparation? Again, it's like preparing the patient for any refractive surgery, comprehensive measurement and assurance of and do the planning, patient counseling, setting the realistic expectation and addressing the patient concerns. What I would recommend at the beginning, under promise the patient and over deliver, because usually in the first few cases while the learning curve, the patient might not gain quickly the visual recovery, especially like first 4 or 5 cases. So at these cases, because usually the company promoting that you will gain vision within 1-2 days, 20/20 vision, which is really not true at the early cases during the learning curve. Marking access for astigmatism is very important because the machine still does not have compensation for the cyclotorsion of the patient, so it's very important to mark the access before going for the procedure, and reviewing the data while entering in the machine and following the nomogram of the machine is very important. So some of the important tips during surgery, during docking, just avoid the head of the patient is being tilted. You need the eye to be parallel to the horizontal axis. I'll show some photos with a less fluid, so you will have a better suction. If you have a lot of fluid interface, suction will be loose, so you might lose suction while doing the surgery. Incision, the centration of the lenticule would help you getting a good results. And during the lenticule dissection, smooth maneuver to ensure clean extraction gently. And usually there is, sometimes we could see something which is called a bubble sign. I will show it to you. And always be careful during while you are entering the wound, be careful about the edges of the incision because it's small sometimes. During the learning curve, you might tear the edge of the incision. So this is the patient interface. You need to make sure that you are centering it very well, so it will be easier while you are docking the patient. This is what we need to do just to make sure that the patient is flat. Avoid the nose. Some patients have a big nose, so you need to tilt the patient head and make sure that it is flat. So, okay. This video will show like what we do during, so now we are putting the patient interface, and then once it is centered, we'll start the vacuum, so the suction will start holding the eye, and then we'll start docking the patient. So now it is touching the cornea, and we monitor the pressure here. They usually recommend having pressure around 20 and not more, because the more we put pressure, the more we will compress the corneal tissue, and it will make it difficult to get out the lenticule and during the dissection. So now after doing the centration, then the laser start by cutting the posterior surface of the lenticule, then it will do the ring, then will do the anterior surface, and finally it will cut the incision. It takes around 17 seconds. It's up to you. You can do it as whatever you like, if you are right-handed or left-handed, so what is suitable for you for the incision, which make it easier for you to go inside and dissect. The recommended is 4, but you can make it larger at the beginning at the area cases, so it's easier for you to move in. Okay, oops, طيب. This is due for doing the dissection. So what we usually do at the beginning is we go from the incision, and then we go to the tunnel. After that, we try to go to the anterior part of the lenticule. Like if you are trying to push the edge of the lenticule, so you could fold it, and then you make sure that you are going above. The most difficult challenge, or the most common challenge that happen in the early cases, is to know either you are anterior or posterior to the lenticule. If you did dissection of the anterior lenticule first, it will be much easier for you to go for the posterior, because if you started with the posterior and you start dissecting, you are like pushing the lenticule anteriorly. It will stick more, and it will be more difficult doing this. So we are doing the anterior lenticule dissection, going all around 360 degrees to make sure that it's very smooth. Sometimes it would be easier if you hold the patient eye with the 0.12 to fix the cornea, but it's somehow painful to the patient, so I prefer doing it without it. So after doing the anterior, you go inside again and push down, and you will see here like the 2 lines that you are posterior to the lenticule. Once you are moving posteriorly, you will see that the lenticule is moving itself even. So it will be easier, just it's here folded already. So you just go after it inside and do lenticular excess, and you will get it out. This is what I was saying, just be careful about the edges of the wound while you are doing the dissection, because sometimes you concentrate in the lenticule and you tear the edge of the wound. So just now I'm holding the lenticule and just make sure doing like lenticular excess, and it's out. And usually if you do spread it, just to make sure that it's circular and complete, just no remaining particles inside. Just I'm washing from inside, and then we'll do ironing, and that's it. I usually put bandage contact lens. One of the issues that you might notice sometimes, even at the early cases, that while you are manipulating, the eye gets dry, and we are patient moving his eye, so you might have sometimes corneal abrasion with the edge of the speculum. Can you raise up? I can't hear you. Okay. No, you just do like ironing and dry it, and that's it. Okay. So one of the technique I found it easier to know that you are anterior is if you go inside from the tunnel. I'll show it to you here. Just you are pushing the anterior part of the edge of the lenticule, like when you are doing DASIK, like you're peeling the descending membrane, and you will see the edges folding, and it will show you how to know that it is folded. Like I'm going here through the tunnel, then I will try to push this edge of the lenticule so it is being folded. So once it is folded, it will be very easy and clear that you can know that you are anterior to it. Now it will be easy to go inside and dissect anterior and posterior, and that's it. About the bubble sign, while the laser is coming, sometimes these gases will accumulate anterior to the, you will not be able to see it all the time, but sometimes if it is there, it makes your life easy to know that you are anterior. So if the bubbles came and accumulate anterior to the lenticule, you will see it like this, as what you see here. This is the bubble at the center. So if you enter and the bubble disappears, then you know 100% that you are in the anterior to the lenticule, dissecting the anterior part. And if you are entering posterior to it, you will see the bubble still there and it will not disappear. Yes. This is the central bubble here. It is anterior to the lenticule, between the lenticule and the cap. So if you enter and you are in the anterior part, once you open it, the bubble will disappear, so you are anterior to the lenticule. You know that you are dissecting the anterior plane. But if you are posterior, it will be still there. If you are moving and the bubble is still there, then you know that you are posterior to the lenticule. Again, here is the bubble, and here while you are dissecting posterior to it, the bubble is still there, but if you are anterior to it, the bubble will disappear. This is video, we'll show it. You see now the bubble disappeared completely as you are anterior to the lenticule. Sorry. Yes. For recording? No. The machine has no microscope, by the way. So you're doing this under the microscope or under the wind or the refractive machine that you have. So what common challenges that you might have during the procedure, like suction loss, repeat docking, which is really very rare to have a suction loss. I had no cases with suction loss. And avoid small eyes and deep sunken eyes with a big nose at the beginning, at the early cases in your learning curve. Difficult lenticule extraction. Usually identify the correct plane and make sure that you are always in the anterior. Scratch and fold technique is the one that I show you that when I am trying to push the lenticule and fold it so I can go anterior to it. With incomplete or irregular lenticule, just go again and try to remove the remaining part if it is there. That's why we spread the lenticule and make sure that it's circular. So we make sure it is complete. Epithelial defect might happen sometimes, so just gentle manipulation and you can put lubrication and bandage contact lens. Surgeon learning curve is manageable and it is really easy. I would say like first 4 or 5 cases and it will be very easy for you to do it. So what post-operative complication that you might see, interface haze or debris, it's rare and usually transient. Inflammatory stromal keratitis, usually with the first few cases. So what I would advise is that using a very frequent steroid like Dr. Shetty said, Q1 hour or Q2 hours for the first days, and it really helps. I noticed that in the first few cases that when I used like QID or something, I had some cases with a stromal keratitis, but after that I learned to give very frequent steroids in the first few days, then I noticed a very dramatically improved vision of the patient. And if there is residual refractive errors, so to go for under or over correction later on, or just the nomogram, like if you have a problem with it. So what I noticed with my experience, 92% of my patients achieve 20/40 vision or better within 1 or 2 days, and 98% achieve 20/20 within 2 weeks. all patients were happy and would recommend the procedure to others. So I hope that future of Silk will treat hyperopia, presbyopia, will go for turbo-guided treatment and the AI integration and machine learning, which would give us really the benefit of the new technology. So in conclusion, success with Silk depends on 3 pillars: careful patient selection, refined surgical technique, and clear communication, which will make it easier. Key takeaways: Silk is a safe, effective, and promising technology. Manageable surgeon learning care, which is really easy, and precise patient selection is crucial, especially at the first few cases, and effective patient communication will drive the adoption. Thank you very much.
Thank you, Doctor, for this very nice lecture. Regarding the course of steroid, what type of steroid do you prefer? Do you use potent steroid like as a routine Brit 40, or you can use, for example, fluoromethalone as a routine? And for how long do you use the steroid for those patients?
I usually for 1 month using prednisolone acetate like Predfort, Q 2 hours for the first 2 days, then tapering over 1 month, QID, TID, BID daily.
Thank you for the wonderful presentation. I mean, you mentioned the residual refractive error. How are you going to treat this patient?
Honestly, I had no residual refractive error till now. I'm not just a beginner. We have the machine like for 6 months. Till now, all cases are doing great. But I think Dr. Shetty said that they had 1 case where they did PRK. I usually use the speculum, except for the small eyes. You can go direct with the patient interface and do the docking without the speculum, and it works.
Thank you so much, Dr. Waseem, for a nice presentation and illustration of surgical steps. I have done quite few cases of smile few years ago, and I struggled in the 500 device at that time in dissection.
Okay.
But I found some tricks during surgery that you can utilize. You highlighted a good number of tricks, but one of the things that mentioned by experts who do thousands of lenticule extraction, as you said, when you go to the superior dissection, you go a wiper technique movement, so you can dissect 360 degree. Then when you enter the pocket in the posterior aspect, they recommend to dissect, leaving the edge 360 degree, so the lenticule will not fold, and you miss a very thin lenticule, sometimes giving you difficulty in dissection. Then when you finish the 360 degree, you go to 1/2, dissect, leave 2 clock hour of hinge, then go to the other one, dissect completely, then you pull that hinge, so you are sure that the lenticule is really taken completely, especially in the early cases where you have difficult dissection and the learning curve is difficult. Also, one of the tricks, or sometimes they recommend if you are thinking that there is some returned lenticule or whatever, is to inject Brit 40 inside the pocket to stain the remaining tissue. And also, you've highlighted clearly that you have to be careful when you dissect the sides. If it's aggressive dissection, you might tear the wound from the side, especially if your movement is not like wiper technique, like the fake chopper technique movement. You might tear the edge so easily. And one more comment is in the early cases, better to avoid the low refractive error cases because it's very thin lenticule.
Thank you so much, Dr. Majid.
Regarding the cycle torsion and astigmatism correction, do you feel safe to do purely astigmatism correction as a lenticule option, like -3 pure astigmatism?
I didn't do pure astigmatism till now. I didn't have a case, but I did like -2 myopia with a -4 astigmatism.
Okay.
Yes, and I had a very good results.
Mixed astigmatism. Have you done any mixed
astigmatism? It doesn't treat
astigmatism?
hyperopia till now, so just for the myopia.
Okay.
And
even mixed astigmatism cases you didn't do?
No.
Okay. Any comments? questions? Any comments? Any comments?
Tari, I'm just coming to ask about your experience. Do you find it like practical doing the cut, then shifting the patient to the microscope? Because this is what we face in the femtosecond cataract in the early cases where like
Honestly, it's better if you have the microscope at the same machine, but we have it in the same room. So what I do is just move the bed to the, we have the Schwind excimer laser, and I'm doing under the microscope Schwind.
Labs, and will it fully replace maybe if someone...
Yeah, it do flaps, but no AKs or ring till now.
So it hasn't really replaced an intralace totally. Okay.
Yes.
If we go to the incision, is there any difference between the nature of the incision? Is there any difference why they call it smooth?
Smooth because it's really a smooth dissection. Because the gapping is, it's like no gap between the laser spots. So it's really very smooth when you go inside and do the dissection.
But we do the same in smile also. It's just terminology, huh?
Yeah.
There's no difference in the... What is the length of your side cut?
4 millimeter.
4. Because in smile we do 2.
Okay.
So even smaller.
Thank you, Dr. Waseem. Thank you very much for accommodating the request and coming in a short notice to reflect your experience as one of the leadest people for now to do silk. And hopefully we join in that journey on the same level. Now, our last part of the day, we will demonstrate on the silk machine. So the screen part will be connected to the projector, and everyone can be seated and they can see how the patient is worked up before the surgery. Then regarding the microscope, unfortunately there is no connection, so it will be done one by one or two on one eye, and we have like around 15 maybe eye samples to work on. Thank you for all the attendees, and hopefully we repeat such great experiences again in the near future. Thank you.
خلينا نسيميوليت كده حاجه بسرعه ويلدر.
مش مشكله، بنحط اي شيء تحت بوكس تبع هاي الهولدر. انزل.
مش هيقدر ينزل.
ترى على فكره مريض راجعت عرفت كذا بقول لك اكلم كونسل. انا وقفت الاستفاده عشان هيل. اوكي. ستيل نوت ما صار في سكار. لا انا برضه شيء لقيت عندي الاستيكاتيزم بالريفراكشن 6 بالتوبوغرافي 3. ايوه. فكنت وقفت الاستراد حتى قريب، اعطيت كروس فراغات قريب، وانا الان قاعد اشوف. اي. فانا كاتب في النوت، طبعا جلست اتذكر هو منه بالضبط 100%، في مره اذكره هو جلست افهمته، بس انا كاتبها ريتم ستيرويد فور هيلينج. اوكي مع انه ما اذكر انه يعني انا بالعاده اذا شفت المريض فقع بالستيغماتيزم وات ايفر اوكي، بس لا كان هو 5 4.5 3 يعني كان ينبوب 3 بركه. مع ذلك الفراكشن الاخير لقيت عنده 6. استغربت. بس يعني ما جلست اثبت ايش السالفه بالضبط. فلا خلى موقف الستيرويد لاني كاتبها. خلى موقف الستيرويد كل يومين يصير. قل له بعطيها بشهر 9 مرات بعد الاسكالس. الاثنين. الحقيقة كيف حالك دكتورة طيبة؟ الاثنين. السبت. يعني أشغلني. يا أخي أنا في مريض عندك أتذكر. أي واحد. بي من حائل مروق هذاك مقبل. أي. هذا ما هذا. أي لا. طيب ذا بس إنه ما ندري شو. البي تي في غالبا تلقاه هاي دروبس ولا ديب سكارز قبل. انا شوف هاي دروبس ما هاي دروبس هذا هاي 6 من سنتين بعدين هاي دروبس بكبير والديب سكار على حسب انا وش مزاجي وش وضع السكار. بعضهم السكار في سكار دنس لكن اغلب السكار انتيري. في بستير اكستنشن بس اذا وصلت 50 مايكرون كذا تلقى اموره بكره تشوفها على السكرات تلقى ما كان في سكار. هذا اوكي. اما مريض سكار قال كذا وكذا واصل في لا بكي بي اقصر ابو 30 حتى ما فكر كثير اقص 20 لا اقول يا اخي ها والله اي انا والله انت الموضوع. I do believe الكبير lives longer. I do believe that يعني. لكن المريض ما جاني عشان شيء live longer، جاء عشان يشوف. بس أنا أقول لك المريض جاي عشان يشوف وجاي بالضبط. فإذا قلت إنه لا جيت هنا بعد قلت لا.
زد 8 زد 8 هذا ترى برضه يمدحونه. هو على الزد 8 والله. وشيء اسمه جهاز كذا تمسكه بيدك كذا تحط يمين تحط يسار وتسوي الثاني حق يس يس. هو طبعا يد she was last seen
دلوقتي بعد ما نخلص هنا هنشتغل على الميكروسكوب. هتحرك الترابيزه. ايه الميكروسكوب بيجي هنا. الميكروسكوب هيجي هيخبط في الجهاز. من قلب الطاوله طبعا. السلام عليكم. مساء الخير. طيب ممكن أنا I will demonstrate the software and you can all see the screen I guess. So once we do the cut on the under the laser, we are going to move to the microscope.
طيب اوكي.
ما كانش في وقت يعني لو كان في وقت ان احنا نغيرها انا كنت كنسلت كله.
كانوا كبرناه.
بس سامحينا
على خير ان شاء الله. Assalamu alaikum. We will start the live demonstration of silk on animal eyes. So, for those who are in the room, just please pay attention to the dissection and the at least one case. كيف حال دكتور؟
Okay. So this software is a profile-driven software. Basically, first thing we do is we create a profile for the doctor. So, again, any doctor who want to use the machine, we are going to create a profile for him. This profile contains all his preferred settings. So after choosing the profile, we are going to create the patient by adding the patient data. First name, last name, and ID. Then we are going to add the date of birth. We're going to choose whether OD, OS, or OU. Then we are going to add the cornea thickness. Now, we can choose either flap or silk. So the parameters for flap is the normal regular parameter, which is the depth of the flap or thickness of the flap, the diameter, the hinge angle. So let's go to the silk and see the profile. So first thing we are going to add is the manifest sphere. So for example, if this is a -2 sphere, -1 cylinder on axis 60, then we are going to add the sphere adjustment as per the nomogram. For example, it's going to be -0.5. Then the cylinder adjustment is usually 10%, so we are going to make it 0.1. It's also provided with the printable nomogram. Then, as per the topography, we are going to choose the flat K and steep and flat K. So this is going to be 44, and this is going to be 45. Okay. Now, these are the basic data, or the basic parameters. We are going into details. So, first thing we can see is the lenticule energy in posterior, anterior. Then we have the ring energy. Then the entry energy, the entry cut, and the entry position. Now, lenticule energy, basically we have a nomogram for the energy which we can start with. But usually what we do at the first few cases that we increase a little bit to make the dissection easier. However, as Dr. Rohit, Shetty, and other users, they have monitored that the higher the energy, late it will take for visual recovery. So we are going to choose the energy, the lenticule, anterior and posterior. Then we are going to choose the entry position. This is based on the doctor preferences. We can use it, for example, on, we'll make it 90, 0, or 180. We can make it here 110. Entry width, we can go from 3 up to 5 millimeters. This is the incision that the machine is going to create, so it can facilitate the removal of the lenticule. Next thing we are going to change it or use it is the anterior depth. Anterior depth is where the lenticule is going to start in the stroma. Usually we start with 110. We can go higher, we can go shallower to 100 microns, or we can go deeper if we want to do more reserve for nerves, or we can go shallower if we're going to we have some challenges in the thickness. So, also we have optical zone, we can change it. We can have it from 5.5 up to 7 millimeters. Usually we start with 6. Then we have the flat add. Flat add is a plano add to the lenticule, which is going to help by increasing or decreasing the thickness based on our need. So if you are doing, for example, a a low myopia patient, -1 sphere or -2 sphere, and you want to increase the thickness of the lenticule, you can go up to 30 microns for the flat add. On the contrary, if you want to save tissue and you want a smaller lenticule, you can add a 15 microns flat add. Next thing, very important, is the lane length, which is the lane length used to get this manifest refraction. Basically, it's the distance from the patient's eye to the chart on the wall. So it's going to be 6, usually it's 4 meters in most of the clinics. So these are the detailed and the basic data that I have. And you can see here that this is the optical zone, which is 6 millimeter from here to here. And here we have the transition zone, which is basically acts as a corridor. So from the entry cut, the surgeon can go inside the corridor to access the anterior or to access the posterior using this corridor, which is represented by the transition zone. So I'm going to go next. Now here we have the data, so we can review. Then we can move to the procedure itself. So I have installed already the cone. We can see it now with the wet lab. So first thing I'm going to do, I'm going to scan the patient interface. You can see 3 dots. Whenever the cone is installed properly, these are going to turn to green. If the scan is not successful, means that the patient interface is not installed properly. There might be some elevation or misalignment. So next, I'm going to install the vacuum. Can I get some help here? Ramiz or Muaz? بدون gloves, it's okay. بس روح شغل الsuction. So I'm going to put the suction ring. Of course, on human eye, we're going to see a trace from sclera or limbus. I'm going to press firmly. Suction, please. So now we have the green indicator with the timer on the top. Once it's green, that means we have a good suction. Now, this is an automated suction which has 10% tolerance to compensate for suction loss. So if a suction loss occurred and it's less than 10%, then the machine is going to compensate for it. So you're not going to have any suction loss if the movement or the change is within 10%. Then I'm going to go down to start the docking. Focus, please. We have here autofocus. Now I'm going directly to the eye, avoiding the ring. Now, as you can see, that there is an indicator here for pressure, which is 3 levels. We have the gray, the green, and the red. We don't operate either in the gray or on the red. The only operatable situation is when it's on green. So I'm going to go down until it's in green. That means we can operate. Now, Muaz is going to lock the joystick. Now, in this case, we cannot move the joystick. Whatever I'm doing, right or left, up and down, I cannot move it. The only movement we can do is from the software. So here, I can move the lenticule itself to center it on the pupil or wherever the doctor wants to. And from this cursor, I can compensate for cyclotorsion. Of course, I'm going to be following the marks that I have done previously. Next thing, I'm going to press on the foot switch. I'm going to click on treat. Then I'm going to press the foot switch. So the machine is going to start with the posterior. Sorry. Then the anterior. Now the ring. Now anterior. Now the entry cut. And now I'm done. I'm going to press on undock. So the machine is gonna go, it's gonna stop the suction and go up automatically. So this is the procedural flow. By this, you have created the cell lenticule. Then we can move to the microscope to see what's the recommended way to remove the lenticule. If you'd like, because the microscope doesn't support broadcasting to screen, we have a small screen. If you can have a group of 5, for example, just to see how we facilitate or how we get the lenticule, you are most welcome.
Any comments or questions for patient preparation? I think it's pretty easy. Maybe something to highlight that flat add is not a corrective number. It's just a thickness number for low myopes to be corrected comfortably or for the lenticule to be thick enough to be manipulated. We had a question earlier, me and Dr. Waseem, and also with Amr, about the lane length. Because it is the lane length taken for the refraction in that room by the optometrist. So it could be 6 meters, could be 4 meters, could be 3 meters. I don't have the answer actually why this is important enough to be added as a number in the machine. Could be related to the extended depth of focus that they are trying to build with the refractive correction. Could be something different, but it's I think something interesting to know why it is a major number to be added. The floor is open for questions, for comments, and to also to join in the microscope if you want to see things closely. After maybe the first group, we can have, as I said earlier, 15 samples to work on. Dr. Jbeir, you should be on the top of the list to join. Dr. Mahanna. عنود لا طيب things are يعني قالوا it's very simple ها no need to wait ما في أحد على هناك ترى إلى الآن. دكتور يزيد.
شيل هذه فوق ونزل هذه المخطوطة. شيلها ونزل ينزل لك. أنا لو زدت الماجنيفيكيشن جيم كذا أسهل لك. فوكس أبقى
طبعا انتم شايفين انه انا مش واضح وين الانتري وين كذا مور زوم.
في ماجنيفاينج بالستيب هذه يعني.
انا بصراحه مش شايف.
سوفت.
احنا اساسا شو بدنا نجيب دي؟
ايوه عشان العلم محطوط في النص صراحه امبارح بالليل. عايزينها في بالليل. تعرف لا لا انت تعرف في اوروبا واحنا بنعمل بيقول لك لازم بيجز او خد بالك الراجل ده كان شغال على الميكروسكوب ده قبل كده.
انت اول شيء بدك تتاكد اذا الانترفيس مركب مظبوط او لا. هيمسك الانترفيس من نفسه ولا يكون في كود. لا يو كيب بريسنج داون كيب بريسنج داون تلاقي ان يكون في كونتاكت بين هذا الجزء السيليكون مع كل هلا اول شيء ما كان في لا مو ديفايس مني انا ما كنت عامل دوكي الديفايس بريد انا
you.